the last section of the lecture for positioning until your sophomore year. We'll go back through some projections, pick up some of the special projections. Amy will cover some of those, and then we'll look at the most common projections again in context of how to correct for positioning errors, things like that. So, last section, test next week, and then final the following week. Yeah, woohoo!
Crazy.
What's that?
That's crazy.
So, and again, you know, you made it this far. First two semesters are really killer semesters. And if you make it through the first, you should make it through the second. If you make it through the second, there's no reason that you shouldn't graduate. It's rare that we lose somebody after the second semester. That's not to say that the first semester of your sophomore year is still going to be tough. We're going back through it. Excuse me, I just leaked all over the place. We're going back through imaging in the. I guess I ought to shred those tests and reprint them. They were kind of marked up anyway. So where was I? We're going back through imaging first semester whenever we come back in fall. So next semester is all online, and it's kind of tedious, and you got to keep up with some stuff, and there's a lot of work to be done, but it's not hard. The tests on the subject matter next semester are, we kind of do them kind of like what you would do for continuing education. So they're kind of open bookish, right? So Amy's class is a little bit different, but the advanced procedures, that's basically what it is. And we'll talk about that maybe next week after the test, just to kind of give you an idea of what we're doing next semester. So, don't let your brain go completely asleep over the summer semester, because in the fall we're going to jump back into imaging, and it's the same grind as what it was this semester. It's just that we're going to go through it a whole lot faster, and we're going to do it twice. So back in the spring or in the fall semester. So sinuses is where we are today. Essential projections, what we're going to talk about, are things that we've already talked about. There's nothing really new in this portion. There's two modifications that we're going to talk about, but for the most part, every one of these we've talked about before. So the only difference is central ray location and collimation, right? We're looking for the sinuses, and albeit the mastoids are technically a type of sinus in that they are hollow, with little air cells, even though you don't breathe through them. They accomplish some of the same things that your sinuses do without the resonation and the warming, but they do lighten the bone. So technically they are sinuses, but we're not talking about those. So we don't have to have the mastoid processes on the image. What we're looking for are the paranasal sinuses. So frontal sinus, maxillary sinus, sphenoid sinus, ethmoid air cells. So everything is in the front. So what we're going to talk about is lateral. We're going to talk about the Caldwell all over again, but there's going to be a little bit of a modification in the Caldwell. We're going to talk about the waters with modification in the waters, and then we're going to talk about the submental vertex, so the SMV. We're going to look at again. So technical considerations, what we want in sinuses is we need to see air fluid. Even though the fluid is very viscous and it doesn't move a whole lot, we can still see air fluid levels if you have a patient upright. So we have to have a patient upright, and they really kind of need to be upright for a few minutes, just to kind of let everything settle, because again, it's very viscous, and if you just stand the patient straight up, then chances are if they have a sinus infection, it's not going to settle down quite as well as if they're upright for a few minutes. So, if you bring the patient down on a stretcher, a gurney, whatever you want to call it, you might have them sit up for a few minutes before you take your sinuses, right? So most of the time they're going to be in a wheelchair. Most of the time also they're going to be ER patients as well. So with the patient upright, of course, if we're looking for air fluid levels, we want that horizontal central ray, just like what we talked about in decubitus images, right? So we want a horizontal central ray. Anything away from horizontal is going to obscure the air fluid levels, if only a little bit. if you look in your Merrills, it shows what a central ray angulation does to the water in a coconut, right? So if you have a horizontal central ray, you see good air fluid level. With any kind of angulation, you start to see the front and back of that air fluid level, and that sharp line goes away. So I got to throw my opinion in here and there. If you look at the images of those coconuts, though, they use a 45-degree angulation to demonstrate that, and you can still vaguely see that air fluid level. So that 15-degree angulation, by the textbook, you need a horizontal central ray, but that 15-degree angulation on the Caldwell, probably not going to interfere all that much with the air fluid level, in all honesty. Potentially it could if the sinus was completely full. So what I'm trying to get to is that if you see a technologist shooting a Caldwell for the sinuses and they use a 15-degree angulation on the central ray, don't get in a twist about it, all right? You might ask them about it after the procedure's over with, and ask them why they didn't use angulation of the head instead of the central ray. But I wouldn't call them out in front of the patient. That'll cause an incident. So anyway, shielding, again, shielding is kind of a little up in the air right now. So even though this says shielding, and most of our hospitals right now still utilize shielding, and even some of them are up in the air about it. Just follow hospital protocol. If the protocol is to shield, then go ahead and shield. If it is not to shield, then don't shield. But you certainly want to collimate. Since we're going to be centering towards the front of the skull just to catch those sinuses, we want to make sure that we use beam restriction, collimate the down as closely as we can, small focal spot, and make sure that we have no artifacts. So what you would want to do is ask the patient if they had any kind of removable teeth. Something like a collar, a necklace is not going to get in the way. Earrings might, so on the lateral, so the earrings probably need to come out. There are things like glass eye that, who would, that's going to be a rare incident. Somebody might have a glass eye, but anything that could obstruct the image, you want to make sure that you get it out. So lateral projection, wording in your test questions. The lateral projection, you see all four sinuses, you see the anterior to posterior dimensions. That's pretty common sense. So you're in lateral, so you're going to see anterior to posterior dimensions, right? You see the front to the back. So you're going to have a tendency to read anterior to posterior, and if you're not completely reading the question and kind of understanding what it is, you get in a hurry, you're going to see anterior to posterior, and you're going to think this, right? So what it's asking you for are the dimensions of the sinuses, right? So what do the sinuses look like? Okay, what portion or what measurement of the sinuses are we seeing? That's the anterior to posterior. So you're going to see the thickness of the frontal bone, and you're going to see all of the sinuses, but especially you're going to see the sphenoid. And the reason that some of your test questions are going to point out the sphenoid is because the frontal sinuses, most of your sinuses are paired, meaning you've got two, right? So you got a left and a right frontal, you got a left and a right maxillary, you've got a number of ethmoid air cells, and they're all going to be stacked on top of each other. So the ethmoid air cells are in two rows going front to back. So you're going to have significant superimposition of the frontal, the maxillary, and the ethmoid air cells, but your sphenoid sinus, two things about it. If it is divided, it's going to be divided in the front and back. That's number one. And number two is, so you're not going to have superimposition between the two if it is divided. And number two is sometimes it may only have one, okay? So the test question will say something about, which projection shows all of the sinuses. Okay, well, that will be lateral. Most of them do, but lateral specifically in this case, but especially the sphenoid sinus, and that would definitely be lateral, okay? So, and anterior to posterior dimensions also. So, lateral projection, you have a patient seated. Understand that sometimes if the patient has sinus infection, they may be a little bit loopy and they may have a hard time sitting upright or standing upright. So seated is probably a little bit better to avoid motion. And everything else is just like every other lateral of the skull that we've seen. Mid-sided planes parallel with the image receptor, mid-coronal planes perpendicular, infraorbital meatal line is perpendicular to the front edge of the image receptor, parallel with a long axis of the image receptor. So extend the chin, position just like every other lateral. This is the only difference. Now we're going to enter about 1/2 to 1 inch posterior to the outer canthus, which is the outer point of the eye. So just posterior to that, which pretty much puts it on the temple. While we haven't used the same orientation for multiple laterals, I'm not 100% sure, but now it's going to be 1 inch posterior to the outer canthus. So your evaluation is going to be the same. We don't want any kind of tilt. We want the orbital roof superimposed. Look at the angle of the mandible if it's included. The angle of the mandible and the condylar processes of the mandible for any kind of tilt or rotation. So all of that stuff just like what we saw before. No difference at all. So it looks like that. So again, what we see is the frontal sinus, but there are two sinuses superimposed on each other. What we see is the maxillary sinuses, ethmoid air cells are all superimposed, and then you've got the sphenoid sinus back here. So the Caldwell is going to show you, for the most part, the frontal sinuses, but it's also going to show you a little bit of the ethmoid air cells. And the tricky thing about ethmoid sinus infections is that if you remember back to when we talked about the ethmoid bone in the skull, we talked about how many air cells that the ethmoid could have in it, and it went from like 6 to 20 or something like that. So there's no way for you to know on each individual patient how many ethmoid air cells they're going to have. That's number one. Number two is that you can't really count them, right? So you got to know how many that they have and how many that you should be able to visualize and be able to count them in order to tell if somebody has an air cell that is opacified, if it's full of goof, right? So it's difficult to make a diagnosis of sinus infection radiographically in ethmoid air cells. So they may have to go to CT in order to visualize that. There are telltale signs. You ever had a sinus infection and it felt like it was right behind your eyes? Yeah, maybe. So clinically, that would be a symptom that a patient has possibly an ethmoid sinus infection. So we're going to see the frontal sinuses, anterior ethmoid air cells, maybe. Sphenoid sinus is going to come through the nasal fossa right below the ethmoids, but you're not really going to be able to make that out because it's behind the nasal cavity. But in our evaluation, we want it just like every other Caldwell with the orbits in the lower third. Now, the reason I mentioned that that bit about the angulation of the central ray is because by textbook, what we should be doing is instead of positioning like a normal Caldwell, an angle in our central ray 15 degrees caudally, since we're looking for air fluid levels, we don't want to do that, right? So we want to leave the central ray horizontal so that we can visualize those air fluid levels and tilt the patient's head back 15 degrees, okay? So technically it's not a Caldwell in the strictest sense, but it accomplishes exactly the same thing as a Caldwell, where our Caldwell is here, right? Our Caldwell, our orbital meatal line is perpendicular, and central ray is 15 degrees caudal. Instead, what we're going to do is keep the central ray horizontal, bring the chin back a little bit, or bring the forehead back a little bit, 15 degree angulation of the orbital meatal line, and keep our horizontal central ray so that we can see air fluid levels better, okay? Still a Caldwell, accomplishes all the same things. It drops the petrous ridges into the lower third of the orbits and helps us to see those frontal sinuses just a little bit better. So in order to, and most of the time it's, if the technologist just kind of freehands this, you know. They just put the patient's nose on the image receptor. It's a guess as to what 15 degrees is. If you're a little OCD and you want that 15-degree angulation, precisely that 15-degree angulation, then you can use the vertical grid device and angle it 15 degrees and put the patient's forehead and nose on the vertical grid device on the bucky. And then you use a horizontal central ray. Okay, so that's just an option for you, and that's what that's describing, is tilting the vertical bucky down 15 degrees. That would be from vertical, tilting the top down 15 degrees. Center at the nasion. Central ray exits at the nasion, column 8. Come on, let's get through this animation. And our petrous ridges should be in the lower third of the orbits, just like every other Caldwell. And again, the main thing that we're looking for is the area right between the eyes. So you collimate down to a much smaller place. You remember talking about cones and cylinders, right? Circular collimation, that's what causes that right there, is an extension cone or a cylinder, an extension cylinder or a cone. Just an external type of collimation. So our waters, remember we have two different waters. One is 55 waters, and that puts the petrous ridges just below the floor of the orbit. What's just below the floor of the orbit? Maxillary sinuses, right? So that's not the one we want. We want 37 waters. So extend the patient's chin until pretty close to the mental-meatal line is perpendicular to the image receptor. Okay, so 37 waters, 37-degree angulation. And that should put your petrous ridges down below the floor of the maxillary sinuses. Just like every other waters that we've seen before. So that what we get is this. So we got an orbit. You can still see the frontal sinus, but specifically what we're looking for is maxillary sinuses. Now notice the difference between these two. You see how this one's nice and dark and full of air, and this one over here is a little bit cloudy. All right, so that's a pretty good indication this patient has some sort of something going on inside that sinus. So the thing about the maxillary sinuses is that it is the only sinus that you're born with. All right, so whenever you're born, you've got these things. The rest of them develop over time. Frontal sinus, I think the ethmoids develop sooner than the sphenoid, but they don't develop until you're like 7 years old or something like that. Once in a rare occasion, you'll get pediatric sinuses. You'll get an order for pediatric sinuses. And by pediatric, I'm talking about, little guys, 4, 5, something like that. And sometimes your ER docs put in orders for a sinus, and then that goes to the nurse, and then it goes to the ward clerk or whoever does the data entry. And by the time it gets to the person putting it into the computer, they don't really understand the anatomy and the development of the sinuses, right? So I've had patients, pediatric patients who, like a 4-year-old, that were ordered a sinus series, okay? Remember, your first job and your first obligation is to the patient, right? Not to the hospital, not to the doctor, not to anybody else, to the patient. So you're the advocate for the patient. So you know that a 4-year-old is not going to have a frontal sinus, right? No ethmoids, no sphenoids to consider. The only place that they could possibly have a sinus infection is right here. So what should you be doing for that patient? Should you be doing a full sinus series, including open mouth waters and SMV and all those things? First off, good luck with a 4-year-old getting those projections. But number one, that's all that you're going to see because that's all the patient has. So you get a full series order, full sinus series order on a 4-year-old. What do you need to do? And it may not even be, those steps in the process. Sometimes your ER docs are just in a hurry and they put in orders. They say, I need sinus series on this without really thinking about it. What should your entire series be on a 4-year-old? That right there. That right there. That's it. Right? So just the water. So what you would do is go to your ER doc and say, the other ones don't develop until later in life. Should we just do a single shot of the maxillary sinuses? If your ER doc's, worth his degree, he's going to say, yeah, just do that. If he says, no, I want the full series, now you go to the radiologist and say, do we really need to be blasting this kid with all this radiation? And this is all we're going to see, and your radiologist should back you up. He'll call the ER doc and say, let's just do a waters. Or possibly he'll say, if it's that serious, if this kid has so much going on in his head that we need to take x-rays, he probably needs CT. Because it might be something else, right? So be your patient advocate. And, again, my opinion is this is, even on adults, this is one of the few views of the skull we really should be doing. Because, again, if it's worth exposing the patient's head to that much radiation, then it's probably worth looking to see if something else is going on. But in this one view, you can see, again, evidence the patient has blowout fracture. You can see the open orbits. You can see the nasal septum. You can see the zygomatic arches. You can see the maxillary sinuses. You can see the frontal sinuses. Even though it's not ideal, you can still see the frontal sinuses. Okay, so that's my preaching for the day. Waters shows us maxillary sinuses. Make sure it's 37-degree waters. Get those petrous ridges below the floor of the maxillary sinuses. But there is a deviation, and that is your open mouth waters. And I'm going to get to that, just the image so that you can see. That's sphenoid sinus. All right, so with the open mouth waters, what we're going to do is we're going to position just like a waters and have the patient just drop their chin. All right, the key to this is it's still going to be a 37-degree angulation. So a 37-degree angulation, just like a regular waters. But what you need to do is have the patient open their mouth before you put their face in contact with the image receptor. First and most importantly, clean the wall bucky off before you do this, before you do any of them, before you do any skulls, but especially this one, because they're going to be putting their mouth right on the image receptor, right? And not only are they going to be putting their mouth on it, they're going to open their mouth to do so. So what you need to do is you need to position like a waters with their head just slightly away from the bucky. And then have them open their mouth, and when you tell them to open their mouth, just tell them to drop their chin, right? Because if you say, I want you to open their mouth as wide as you can, what are they going to do? Yeah. Right? And if you have their chin up against it, the chin can't go anywhere. So surely, truly, they're going to go, "Bleh," like that. So what happens to your orbital meatal line as that happens? Is it still at the right angulation? The answer is no. And even the mentomeatal line is off, okay? So position the patient close to it and then tell them, I want you to just drop your chin as wide as you can and then have them place their mouth on the image receptor. It'll project the sphenoid sinus through the open mouth. There may still be, I didn't look to be honest with you, there may still be a reference to this view in Merrill's as the Peary method. I don't remember if it came out for this one or not. And the Peary method was sort of like this, but it utilized a central ray angulation. So there used to be two views in the older versions of Merrill's. One that was just the open mouth waters and then one with angulation. So if, in the rare case that you might have to do a set of sinuses and somebody says Peary method, that's what they're referring to as the open mouth waters essentially. Okay. Peary method is extinct now because of the central ray angulation, but it's close. All right, so it's going to show you the sphenoid, the ethmoids, supposedly, and the rest of that stuff is just OG whiz stuff. So SMV, just like every other SMV, you might want to sit the patient down for this in a chair, right? Just like what we talked about before, scoot their hips out to the front edge of the chair. have them lean back and then tilt their head until the infraorbital meatal line is parallel with the image receptor. So that's your extension. Extend the chin back until the OML is parallel with the image receptor. Your central ray is going to enter about 3/4 of an inch anterior to the EAM. So it's really a little bit of a guess as to how to get to that. It's an estimation, not really a guess. And our evaluation is just going to be exactly like what it was for every other SMV that we looked at before. All right, so now, because it's difficult to get a good SMV, it can be difficult to get a good SMV, difficult to get the patient's chin back, even with them in a chair, slouching in a chair. I'm going to say, just kind of off the record, that if you can't get the patient's chin back far enough to put the IOML parallel to the image receptor, go ahead and hit it with a little bit of an angulation to put your central ray perpendicular to that. Otherwise, it's going to tuck your ethmoids into your mandible, into your maxilla, into your frontal bone, right? So what you need to see are the petrous ridges posterior to the condylar processes, the mandible. So if their chin is not far back enough, what that's going to do is it's going to bring those things down, and it's going to obscure your view of everything that you need to see. So even though your textbook says keep the central ray horizontal, if you just absolutely can't get to IOML parallel to the image receptor, maybe that 5-degree angulation is probably not going to hurt you all that much. Nobody's going to be able to notice that, well, your air fluid levels are obscured because of that 5-degree angle. Nobody's going to catch that, okay? So better to do that and than get the distortion that you would otherwise get. So rare case that you have a patient that comes in and they're in a trauma situation, they're strapped to a backboard and you need to get a sinus series. Obviously you can't get the patient up, right? So your sinuses for the most part are just, most of the views are going to be straight AP, right? AP axial waters, AP Caldwell, and you're just not going to be able to visualize them. They're going to be obscured or occluded. So really your only view that's going to accomplish seeing air fluid levels would be what? I think it's a test question. It used to be a test question. What would you do? What do you do in trauma situations for almost everything? Cross-table lateral. Right. Yeah. So, and that may be your only view of the sinuses, but realistically, again, if the patient's in a trauma situation, they're concerned about something going on inside of the patient's head, they're going to CT, right? So it's, it's a textbook question for a textbook answer. And as far as clinicals go, it's just not going to happen. And that's sinuses in 30 minutes.